regular Thursday clinic. We're happy to see you in the audience today. Thank you. We see about 1,200 patients a year, about 3,000 visits. It's all care provided by volunteers and students for medical and dental. And we provide the services that folks would otherwise probably go without. We help people who are maybe between jobs, or maybe they're working a couple of jobs that are minimum wage and they have a health insurance plan with a high deductible. So could be people new to this country, or could be a fifth generation Vermonter. There's no typical good neighbor patient. And they tell us that they feel welcome, safe, respected, and comfortable at the clinic. So I've been there for about 3 years. I can't take credit for it, but I do think we're doing something right. Today, I just want to introduce Dr. Timothy Leahy. You go by Tim?
Tim.
Tim. Tim is an infectious diseases and HIV specialist and associate professor at Dartmouth-Hitchcock Medical Center and Dartmouth Geisel School of Medicine. Tim is chair of the Clinical Ethics Committee, director of education at the Dartmouth Institute of Health Policy and Clinical Practice, and an award-winning educator. Tim has written for the New York Times, The Atlantic, and other popular press outlets. And we're really happy that you could join us tonight and talk about Lyme disease. Thank you very much.
Yeah, thanks for having me.
Yeah.
Well, good to meet you all. Lyme has lots of parts to it as an illness, and it also has a lot of sort of lore attached to it in our society. And I wanted to make sure that we had a chance to touch on all of those things. So I'll try to take you through the stuff that we know happens from Lyme disease, and some of the ways that we try to treat it and help people feel better. And then also to try to get into the kind of the areas of uncertainty around that. As with everything in medicine, there are some things that we just know for sure, and then there's the stuff that we have no idea about and everything in between. And Lyme has pieces of each, and I thought it might be interesting to give you a sense of where I think that unknown is. And how do we deal with that if we know that there are people who feel ill and want to feel better, and there's someplace in that mixture? So obviously, feel free to stop me if I'm not making sense or whatever. So we'll talk about some classic presentations of Lyme infection and the things that trigger just immediate treatment or testing for Lyme. And wanted to talk about not only just the stuff that happens as a result of infection with the agent of Lyme disease, but also some of the other things that ticks can carry with them that can make people feel sick as well. And then we'll get into myths and unknown. So here's a map from a couple of years ago of all the cases of Lyme disease in the United States. And most of them are up in the top right, but you can see that there are little speckles across the map. Most of these cases are acquired here and then have traveled over there, but there are ticks across the country, and so it's possible to catch Lyme in other places. But man, if you're in Utah, you got to be pretty unlucky. Take a deep breath in New Hampshire in July, and it could happen to you. And here are pictures of the Ixodes tick that transmit Lyme. And the one you really care about is the one whose name is in orange there, these little tiny ones called nymphs. They are the ones that have had time to be alive enough to be infected with the Borrelia burgdorferi, the agent of Lyme, to have developed Lyme infection in their stomach, which as far as we can tell doesn't really hurt the tick very much. They have it there, but they're fine. They can grow up to be old. But they also are the ones that are out jumping onto humans, trying to have a blood meal off of us, and haven't yet cleared the infection from their system. So those are really the ones that primarily transmit Lyme disease. And this is not incredibly comforting, because the one that you can see really easily is this one. None of these are to scale, thank God. But the ones that you can really see, the adults don't transmit Lyme very often. It's the one that you can't see that you actually worry about more. And you can see it, it's probably like the size of a tip of a pencil or maybe two pencil dots. So it's visible, but it's just really easy to miss. This is probably why only about 30% of people who have bona fide Lyme disease can remember a tick bite. Many of us have found a tick on our ankle or something like that, and the vast majority of people who have had a tick don't go on to get sick. And most people who at some point we know they had a nip on their body and had a blood meal and transmitted Lyme disease to them, they have no recollection of it because it's not really something you feel and necessarily see. So, my sons go walking in the fields of rural New Hampshire all the time, and I have when they were little, I used to check them, and now they check themselves. But I don't live under the illusion that that's 100% protection against it, because it can happen. So here's a picture. It's kind of gruesome of a nymphal tick that has eaten some human, some blood from a human. And what happens is that they actually have Lyme in their stomach, the agent of Lyme, Borrelia, and they hop on you just trying to have some lunch, fill up with blood, and in the process regurgitate some of that infection into your skin. And so the Lyme is not transmitted intentionally, it's just sort of a byproduct of them nourishing themselves. We think that if you go out, and people actually do this from the public health department, if you just go off into the brush and take nets that will pick up Lyme, if you just sort of brush them through the underbrush and pick up Lyme, these kind of Lyme-carrying ticks, and test them, and you sort of ask the question, how many of those ticks actually have Borrelia burgdorferi in their stomach and therefore could transmit it to somebody? It's about 1 in 100. So there's zillions and zillions of ticks out there. Most of them don't have the infection. Most of the ones that have the infection aren't really very likely to eat a blood meal off of you or very likely to come in contact with them. It takes that sort of multiple overlapping. It has to be the right tick, the right stage of their life, and they have to be actually infected, and then they have to decide that you're the buffet they'd like to come to. And here's the classic thing that you'll see as the first manifestation of Lyme disease. And most people who experience this rash will notice that. But you can imagine if that tick happened to get you on your back. You might not. It doesn't hurt. It's not necessarily very itchy. Sometimes this sort of most intense center of it is typically where the tick has been. You might feel a little itchy, but this isn't like a mosquito bite where you would expect to be able to feel it. You may have no idea. So if it's in a place where you're not looking at it, you might not see it. The Latin name for this is erythema chronica migrans, or erythema migrans, or sometimes people call it EM for short. But this target-like or bullseye rash is sort of classic for Lyme. And I think it's important to say that if you didn't have this ring around it and it was just a red spot, most of us have had some sort of a little skin reaction from a poke we got or a bug bite of some sort, and it doesn't mean much. Your body knows that you've had some sort of an insect bite and you fight it off and it's no big deal. Sometimes Lyme disease can just look like this and not have a ring around it. And so occasionally we'll see people who have sort of an area of redness that's big enough that you say, gosh, that's out of keeping of what I usually see from somebody who's just got a garden variety bug bite, and that's good enough to call it Lyme disease. But whenever you see that ring around it, that gives you near certainty that it's Lyme disease. Not everything that does a bullseye, though, is Lyme. It turns out that there are some times that your body's immune system will act just as if it has Lyme disease, but you don't. So it turns out, for instance, that there are some forms of drug allergy. You take, say, penicillin if you're allergic to penicillin, and you can get a rash that looks like this all over your body. But there are ways that clinicians can tell the difference between the two. One big hint that isn't perfect but really helpful is that Lyme typically makes one spot, whereas those drug allergies typically make a bunch of spots. But I have seen a couple of times people who had really robust Lyme exposure, and they were sort of in a field where there were a bunch of infected ticks, and they had spots all over. So sometimes you can't tell. There's a little bit of an overlap there.
Howdy.
Hey, how are you doing? I mention that partly because this is the most kind of classic. Any infectious disease doc can tell you from half a mile away that's Lyme disease. It's just sort of exactly what it looks like. And yet even here, there's a little asterisk that you have to put on there and say, well, let me make sure and talk with the patient and make sure that they didn't, for instance, start a new medicine that they might be allergic to. Or, gosh, if there was more than one of those, might my degree of certainty go down a little bit? So even with this most specific cardinal manifestation of Lyme disease, there's a little uncertainty. And as we'll talk about as we get into some of the other ways that Lyme can show up, that uncertainty can grow in other circumstances. We think that probably everybody who has Lyme disease of any form started with this rash. But there are certainly ways that Lyme disease can present itself that have nothing to do with the rash. That by the time they come into care and see me, they have some of the things we'll talk about and no rash. And so was it that they just had it and didn't notice it? Did they have it and think, oh heck, that was no big deal, I don't need to care for that? Or was it that they were one of those people who didn't, body didn't read the textbook and just they had a somewhat atypical manifestation? We don't really know because of course if they don't come in, we don't know. So what are some of those other signs of Lyme disease? So what's wrong? Swollen joint. And that looks painful, right? This is a young girl, I think she was 12 or something like that, that has a big swollen left knee. This is not only easy to see, this hurts like crazy. It's probably really difficult to bend this joint. Might be able to walk with that, but might not be able to walk with that. Probably something that showed up a few days ago as a little sore. Thought maybe I bumped myself when I was, wrestling with a friend, but then the next day, man, that's really sore, but probably could go to school if it's a kid or go to work. But then, wow, I got up this morning and I've got a fever and I can hardly even move that joint. That might be the typical story for this kind of a Lyme arthritis. So notice the difference between this and the kind of arthritis that all of us, experience at some point in our lives. The kind of osteoarthritis, degenerative arthritis that many of us get in our hands, our knees, our wrists maybe, our shoulders. You can't see from across the room typically. This you can see. If you put your hand on this kid's knee, it's warm. It doesn't look particularly red to me, but sometimes it'll actually be flushed and pink. Whereas normal arthritis, the skin of your hands, I have arthritis in my hands, and the skin of my hands is fine. You probably can't tell from across the room. It's a really key distinction to make because, as we'll talk about, lots of us have symptoms of some sort. And sometimes those symptoms can overlap a little bit with the symptoms of Lyme disease. So I showed you the picture of the bullet rash, the target rash. There aren't a lot of things that look like that, so usually when you have it, it's pretty specific. There's probably a list of 20 things that I could think of that do this. Most of them are infections. Not all of them are Lyme, though. But how many of us don't at some point have a sore knee? So you can imagine how there are people who show up in a clinician's office and say, man, my knee's really hurting, and wonder if it's Lyme disease. And you can usually take that off the list of possibilities if it's not warm or swollen. It's really unlikely that it's Lyme disease. Not 100%. So there's that uncertainty starts to grow here. So here is a normal diagram of what an EKG is supposed to look like. So cardiologists, when they're looking at an EKG to decide if somebody has a heart attack or if the pacemaker, if somebody's heart's not functioning properly, they'll look at these squiggles that we all see on the TV screen and the monitor in an ICU, and they'll sort of look to see, is there a P for every R? Is the Q and the R and the S of the right shape and size, and does the T follow them in the correct order, and are they all sort of about the right distance from each other? John spent a lot of time in his life scrutinizing EKGs and getting these things clear. And here is an EKG tracing for somebody who has another manifestation of Lyme disease. one of them that often does not show up with a rash and can actually come in somebody who has no idea that they had Lyme disease or maybe blew off a little redness in the skin, and then they show up with an EKG like that. So notice with this normal diagram, the first thing you see is this little bump, and we call those P waves. In this EKG, here's a little bump, 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 and you can see these little tall spikes are not following after it. In fact, if you trace this out a little bit longer than I've shown on the screen here, you can actually show that not only is there not one spike for each of these little bumps, meaning you're not having the full normal bump, spike, bump pattern that you usually have, but that there is no relationship between when these little bumps happen and the spikes. So why is that important? Why am I talking about bumps and spikes? It turns out that this bump is the pacemaker of the heart firing. This spike is the heart responding with a pump. And this EKG is actually a tracing of the pacemaker of the heart firing and the heart not responding. So this is actually a tracing of what a clinician would call complete heart block. So the patients, when I hear a complete heart block, I might think, oh gosh, that means the heart's not doing anything at all. It turns out what's happening here is that the pacemaker of the heart is firing, and then the heart can't respond to it, so it's making up its own beats. It's sort of saying, well, I'm dead if I don't do this, so I'm going to make up my own beats. This is actually one of the classic ways that Lyme infection can happen. So the story is that a tick gets me, maybe in the back of my leg or some other place I don't see it. Eventually that rash goes away, and I might have had a fever and thought it was a cold, but then I was fine. And then maybe 3 weeks later, I start feeling really, really tired. And maybe it's a little hard for me to breathe. And gosh, every time I get out of the chair, I practically pass out because I just, dizzy as all get out. I go in and I see this, and my cardiologist will say, or my emergency room doc will say, you have complete heart block. The Lyme infection has infected the wall of your heart, caused irritation and inflammation of the heart right at the place where the pacemaker is supposed to transmit its impulses down to the heart to make it pump, and that circuit is disconnected. So this, of course, is a dangerous one. It's one thing to have a target-shaped rash and the fever. That's no fun. This, on the other hand, can get you in the intensive care unit. So far, I haven't told you about anything that isn't curable, and that's the good news. So I've told you most of the major things. I told you about that bullet, that target rash, called erythema chronicum migrans, and then I told you about that monoarticular arthritis, and I wanted to loop back to that. So I told you that there are lots of ways that our joints can be sore. You can have arthritis, but when your joint is swollen, then you begin to think, an infection like Lyme disease or some other infection is likely. It turns out that the Lyme infection is typically, almost always, like this, one joint, monoarticular, one joint. Whenever I see somebody who has, say, lots of joints involved, I start thinking about something else. Some viral infections will cause that. Some kinds of autoimmune disease like rheumatoid arthritis can cause that. It'd be pretty unusual for Lyme to get into multiple joints. Not never, but unusual. The other thing that I've never heard a good explanation for is that Lyme likes to involve certain joints and not others. So I've actually been here for 12 years, and I was in Boston for 3 years before that. I've never seen a joint other than the knee involved. It happens, but man, it's unusual. So Lyme involvement of the shoulder, gosh, I could probably get published telling the story of that if I could. I told you about complete heart block, and then in this list are a couple of things that are a little bit less common, but things occasionally you'll hear about as caused by Lyme disease, and they definitely are. So aseptic meningitis would be You probably hear stories on the news periodically of a young kid who's really gotten desperately ill from meningitis. There was a case of a football team in Connecticut last year where one of the players on the team got sick from a really highly contagious, really life-threatening kind of meningitis, and then one of the other players got it, and all the parents and kids were frightened, and all the kids got on preventive antibiotics. It's not that kind of meningitis, but it has a little bit of overlap with it. Where you get a high fever, a really bad headache, and the light really bothers your eyes, and you probably can't work. So it's enough to take you out of commission. You might be able to tough it out, but it'd be tough. But it won't kill you. But it can make you good and miserable for weeks and weeks and weeks. And if untreated, can make you have a mental fog for a good long time. It's called aseptic because if you culture the spinal fluid, unlike that first kind of meningitis I told you about, you can't grow anything in the culture because you can't culture Lyme disease. But if you think, oh, wait a second, I see a mild case of meningitis in Vermont or New Hampshire, Massachusetts in the summer, I should look for Lyme, then you can make the diagnosis and treat it and make people feel better. So then here is a picture of the other kind of Lyme disease that we'll see periodically, and that's a facial palsy. You can see that this patient sort of kind of has a droop here on his left face. You can imagine that you want to ask him to smile and go like this, and you might not get much there. It's a little hard to simulate, but I hope you work with me on this. That's probably, or that's definitely, just like the aseptic meningitis, a sign that Lyme is in the central nervous system, involving not the lining of the meninges like aseptic meningitis, not all the way along the spinal cord, but just sort of more specifically a nerve that's gone to the face. You may know that there is a condition called Bell's palsy, where somebody can get a facial droop, and it can sometimes be difficult to tell, is that from Lyme or is it from something else? It's hard to tell because they look quite similar. And so as the list gets longer, the more you see that there's overlap between Lyme. Target rash, one or two things are like it. A monoarticular arthritis, a couple things can get you there. And I could figure them out. Aseptic meningitis, long list of possible things, and I have to be really careful to figure out, well, does the testing suggest it's Lyme or does it not? Because it's kind of hard to tell just talking to the patient, examining them to know for sure. Facial palsy, I treat that sometimes as Lyme, but I never feel 100% sure because there's a lot of things that could be, and it's hard to tell the difference. And complete heart block is actually similar. Oftentimes, imagine if I come in to see John and I say, gosh, John, do I need a pacemaker? My heart's not, I have complete heart block. John has a list of, what do you think, 200, 300 things
maybe,
you could come up with.
More than that, yeah.
It could be a heart attack, could be that there was some ion, electrolyte problem in your body that caused it, could be that you had some autoimmune disease of your heart, could be that you had, and you can keep on going there. I just gave you some categories of things that there are lots of examples of. So is it Lyme? Well, you can usually figure out by what season it is or by what the testing looks like, but you always walk into it thinking, well, I kind of hope it's Lyme because I hope it's not a heart attack. And so this gets into, we'll get into treatment and how we do that. And we'll also get into some of the other infections that cause this. But this gets to kind of an important thing in Lyme diagnosis and treatment, which is that they overlap also. But sometimes I walk in and I'm sure that's Lyme disease, and I'm sure I can cure it with my treatment. Other times I think, I bet you that's Lyme disease, but I'll see what happens when I treat. Because if that gets a lot better really quickly, that was Lyme disease. If it doesn't, I wonder if that wasn't Lyme disease, and maybe that's why it didn't get better. That's hard too, because as we'll talk about, most of the time when you get treated for Lyme disease, you get better. But every once in a while, you don't. And so then you're left with a really difficult decision. Was that Lyme disease that needed to be treated again because it didn't respond the first time? Or was your diagnosis wrong? And so we'll talk a little bit about that. Sometimes you can reach certainty about that, and other times you say, well, I'm not sure, so I'm going to try to treat it again and perhaps a little more aggressively. And then if it doesn't work, I'm going to call it quits and say I was probably wrong with the diagnosis. But you see how the patient stuck in the middle there is wondering, well, what's the truth here? And do I really have Lyme disease? Do I not? Is that the right treatment or not? And what do I do? Okay, so that gets you to this problem, which is think about some of the other symptoms that Lyme disease can cause. I told you about how heart block can be caused by a lot of different things, or a sore knee can be caused by a lot of different things. Those are some of the more specific reasons that somebody might come to my attention with Lyme. But Lyme can also cause fevers, or fatigue, or just people often feel kind of achy with Lyme, just like they do if they have influenza or a bad stomach bug. They just kind of, they can feel their immune system sort of hyped up against this infection. Sometimes they just don't feel like they're sharp. They're, not thinking perfect, they're fine. It's not like they're forgetting everything. It's not that they can't talk, but they're just not quite themselves. Think of how many things can cause that. In fact, what doesn't? I find that getting up in the morning is a pretty good way to feel tired and achy and not quite sharp. And imagine if you are depressed. You will feel tired and probably a little achy and maybe not super sharp. Maybe you had a heart attack 6 months ago and you're in the ICU and you're recovering from that. And it's the summer. And you wonder, since it is the summer in New England, how much of your symptomatology comes from Lyme disease you could have been exposed to while gardening while you were recovering, and how much was from 6 months ago when you were in the ICU? Sometimes it's pretty easy to say, gosh, you don't live in an area where Lyme disease is, your Lyme testing is negative, you're tired because of the things that make all of us tired, you're depressed, or you need to work out more so that you have more energy, or your thyroid isn't active. But other times, it's summer, it's New England, maybe you have a positive Lyme test. I don't know. Maybe it's from Lyme, maybe it's not. It's hard to tell. And that's the trickery that this bug does, is that usually it'll tell you, or it'll raise its hand and sort of say, check out the rash I just made, there you go. Anybody can make that diagnosis. But other times it makes it difficult. And as you know, this is, when you're not feeling good, it sucks. And you want help. You'd like for somebody to give you the answer. And so when you notice that they're not sure, and you worry, am I in good hands? Can I trust this person to do the right thing for me? It can heighten your anxiety. And so this can lead to some challenging conversations, that a patient who really just wants to feel better and is hoping for help and confused by all this too, and probably reading on the internet about this, and that's helping a little and hurting a little, and a clinician who wants to help, wants the person to feel better, isn't quite sure, maybe it's one of those in-between symptoms. They're looking stuff up too, and they're thinking, well, here's some areas of certainty, here's some uncertainty. You're in the middle. It's hard to know what to do. And so what I find is it's really helpful to kind of be in partnership together and say, hey, here in 2017 we know so many things we didn't know in 1817, but we are far from done, and let's work on this together, and I'll tell you what I think is the best way forward, and the safest thing to do for you, and the things that's most likely to help you and not harm you. But I don't want to pretend like I have all the answers, because you shouldn't see a doctor who feels like they have all the answers, because they're probably wrong, True, right? There are times when I've just been like, oh, that's the answer for sure, but most of the time in these difficult situations, there's not certainty. And so I try to partner with people. And as we'll talk about, sometimes it's easy. I just write the prescription and say, you'll be good in a couple of weeks. Congratulations. I'm glad you have a cure. Other times I sort of say, well, let's see what happens. And what I'm going to promise to do is to help you when I feel like I'm likely to help you, and I'm going to obey one of the first things I learned in medical school, which is first, do no harm. I'm going to tell you when I think it would be unsafe for me to do something that would just be an experiment that might hurt you. So, more about that. Here's sort of an algorithm I think about when I am seeing somebody and thinking, could this be Lyme disease, and should this lead toward treatment? So let me walk you through it. So first, I asked this question: are these symptoms that this person is seeing me for plausibly from Lyme disease? Are they close enough to the story of Lyme disease that it seems reasonable to be thinking about Lyme, and not so far away that I kind of think, well, heck, anybody could have those symptoms? It's really important because, imagine if somebody comes in and they say, I'm tired. I said, well, tell me more. That's it. I'm tired. Fevers or rashes or swollen joint. I'm just tired. How long have you been tired? 10 years I've been tired. Gosh, John has a really long list of things that cause heart block, but you don't have time for us to list the things that make you feel tired, right? We'd be here all night and on into the next few months. So that, that's probably not from Lyme disease. And I might just stop there and say, gosh, we shouldn't test the whole populace for Lyme disease. Because it turns out that if you live in an area like this, you can be exposed to one of those ticks and get infected with Lyme. Your immune system remembers it, you cleared it, and you never had symptoms. Kind of like how if I test this whole room for Epstein-Barr virus or herpes simplex virus, some of the other viruses that many adults are exposed to, most of us will show evidence of having been exposed, even if we never had a cold sore or mono or the other symptoms of that. Same thing is true of Lyme. People can be exposed but not have symptoms. So if I take 1,000 people and I test them all for Lyme, probably, 50 of them will be positive for Lyme in a place like this where there's lots of Lyme. And 400 of them will feel quite tired on a regular basis. And some of those tired people will be in that list of 50. So are those the tired people who got Lyme disease and that's driving their tired? Or are they just tired for some other reason that has nothing to do with it? It's hard to tell, and so what we try to do is say, well, if it's at all plausibly Lyme, we should go down this and try to see if that's Lyme. But if it's just, heck, you have ennui, maybe that's time to stop. So if it's not plausibly Lyme, I stop. But I have I don't want to be dogmatic, and so I try to say, well, could be, so let's look into it more. So if I think it's yes, then the first thing I say is, could it be early Lyme disease, or could it be that rash I showed you, erythema chronicum migrans? If it is, I'll just treat that right away, and I won't even do testing. The reason I do that is that that typically shows up within a week or so of that tick bite. It's too early for the immune system to make a positive test. It usually takes, if I was to get HIV infection today, it'd take me a few weeks to make a positive HIV test. And this is true of many infections, including Lyme disease. So if somebody has that classic rash, I could do the test and it would be negative, but what did that teach me? I already knew that it was Lyme disease, so I should just help that person feel better and treat them. So if I see the rash, I just treat and I don't even test. It's not so easy with the other stuff, and so if it's early, I say treat, and this is a picture of the antibiotic we give called doxycycline. That's what we give in most cases. But if it's not early Lyme, and I'm thinking it's that carditis that causes heart block, or aseptic meningitis, a headache, fever thing, or is it monoarticular arthritis, a swollen knee, typically, then I'd say, well, each of those things has a list of possibilities. Let's do some testing and sort of see how close we are to it. So then I do a test. So now you shift forward and you say, okay, I've done a test, and hopefully I did it for a good reason. Of note, if I have a positive screening test, I could have done it for the wrong reason and just have life happening in a positive test. So I try not to do that. I try not to do the test in people who don't need it. Sort of like I don't test cholesterol in 6-year-olds because what am I going to do with that? But occasionally that happens, and so I will see people in my practice who are a little tired but otherwise probably shouldn't have had a Lyme disease. And I'll sort of be really careful not to miss something and then say, shoot, I'm sorry, we gave you a little bit of a false alarm, but I'm worried that's not useful information for you. But usually, when somebody has a positive Lyme test, it's because they had some sort of illness that was plausibly Lyme. And if it's positive, what the lab will do without me asking for it is they'll just confirm it. What they do is they do a first pass test that's really good at picking up Lyme. It'll be positive in as many people as possible with Lyme. We think probably about 90% of people who have Lyme disease, 90-95% of people will have a positive test. but it's sometimes falsely positive. It's sort of, it's tuned to sort of err on the side of false positives, so we don't miss anybody. So what the lab does is if that's positive, they say, well, let's make sure we don't want to lead somebody to treatment that could have side effects if they don't need it. So they just do a second test that's better at discriminating the false positives from true positives. And if that's positive, then we say, that's a positive Lyme test. This gets at another problem of Lyme tests. As is the case with all diagnostic tests, they are imperfect. They pick up most cases of Lyme disease, but they would be expected to be negative if it was really early on, like if you have the target rash. And in some cases, we think they probably miss it. There is no perfect test, and so my guess is there's somebody who's got bona fide, absolutely for sure Lyme disease, and if you were God and looking down, you could sort of say, but that test was wrong about it. Occasionally, we'll sort of try to hedge our bets a little bit by saying, man, that looks like Lyme disease. Let me try that again and do that test again. But occasionally just, I don't know, their body doesn't make the antibodies that test can do, or the test's broken or something. And you're in this place of, how sure am I? Does it look so much like Lyme disease, I'm going to say it's a 1 in 1,000 chance I'm going to try treatment anyway? Or do I kind of think, I wasn't really sure anyway, so I'm going to take that negative? But you get that, this has some art in it. It's not all physics. So if that's positive, if that confirmatory testing is positive, then you get treatment. But if that confirmatory test is negative, it leaves you with this decision. And that's what I was alluding to before, that sometimes you'll treat anyway if you just kind of think, heck, I just believe that is Lyme. It just sounds so plausible, and I'd feel bad walking away from that person, not at least trying to see if the treatment helped them out. And as you can imagine, patients are like, well, why are you giving me treatment if my test is negative? Are you sure? Isn't that going to harm me without is that just going to give me the nausea from the pill if I don't need it? Or, well, I know you say my test is negative and you think that I don't have Lyme disease, but what if I did? Don't you care? It's a challenging conversation, and so we just try to make it together as best we can. And that gets to this test, or this is an example of test. The CDC sets out tests that have been validated, where you sort of take a group of people who have Lyme disease and you test to see how well that one can do at picking up the people who really have Lyme disease versus a bunch of people who you pull off the street who don't have Lyme disease. You tell apart those two groups. It turns out that there are a few different commercial assays out there that different hospitals use, different clinics use to test for Lyme. And there are also alternate test makers that the CDC says are too willing to give you a positive test, even if those other tests are negative. And this enters into this conversation between patients and clinicians about, well, how many of these test results are true positives and how many are not, and how many are true negatives and how many are not. So you can imagine, let's say I see somebody, and I say, well, I follow by the rules that the CDC says, and it sounds to me like you might have Lyme disease, but I'm not really sure. Let's see what the testing shows. It's negative, and they say, well, looks negative to me. I think you probably don't have Lyme, and so I think risks of therapy are probably not worth it for you. And then they go see somebody else, and they do a different test, and IGeneX is a famous Lyme testing facility that's not advocated by the CDC, that I find gets positive results in a lot of my patients who have negative results from Lyme. So they see somebody who uses this test, and they come back and they say, but that clinician saw a positive result, and that person did give me antibiotics. So doesn't that person care more about me than you do? I said, well, that's possible. I don't know how much I haven't measured how much they care about you. It could be more. But here we are in this place, and I think this is probably the first time to introduce the idea of uncertainty in 2017. The best evidence that I've seen is that the test that the CDC recommends that we use are as most reliable, is that's better than these, which I find, my guess is you could probably submit a sample of Kool-Aid and get a positive result. But that's my story in 2017. The history of medicine is full of stories of people who were just convinced that they knew the answers, and then, you know, that answer was thrown into the trash bin of history because we were just wrong. So perhaps these guys know the answer. Could be. So what I tell patients is that in this time of uncertainty, I try to go with a reasonable authority with some humility. And I say that I don't want to harm you by experimenting on you with something that I think probably just willy-nilly gives positive results. But I admit I'm a fallible human. I could be wrong. I'm just doing my best. And you know, I think most people think that's fine, and other people do walk out frustrated thinking that I don't care. I'd say that's probably the devil in this conversation is that latter part is it's not uncommon nowadays for patients to walk away feeling that, oh, you won't give me antibiotics, therefore you don't care. Or that guy said he had a positive test and he would give me antibiotics and he cares. That's the devil in the conversation because patients just want to feel better. Clinicians just want to make them feel better. And whenever animosity like this shows up, it makes me feel like, oh, heck, something's wrong with the conversation because we may not know what to do, but we should all have the same goals. So here's the treatment for Lyme disease. As I mentioned, most of the time, and this is what you do for adults. There are some other medicines that we do for children who can't take this medicine, or generally shouldn't. Doxycycline is a pill. Take it a couple times a day. It works really well against Lyme disease. Most cases of mild Lyme disease are cured by doxycycline. It's not the easiest drug in the world to take it. It makes a fair number of people nauseated, and some people so much so that they can't take it. And it can give you a really bad sunburn, and typically Lyme disease happens during the sunny parts of the year, so that can be an issue. I've had a patient who was taking doxycycline who knew about that risk, used sunscreen, and sat out on her front porch between 7 and 8 o'clock, she says, because she was so careful. But she just had to see that beautiful sunset, and she came in with a 2nd-degree sunburn. Oh. So most people, it's just, it's a little worse sunburn, but every once in a while you'll see that, holy crap, just horrible side effect. That is what we give for somebody who has that target rash. We give it to somebody who has a facial palsy. We give it to somebody who has a mild monoarticular arthritis. But when it's a bad arthritis or it hasn't responded the first time, or if it's their heart, or if it's around their brain, then we tend to give IV therapy. And so this is a picture of a bottle of a drug called ceftriaxone that we give for that IV. And there's some other medicines that we tend to give, for instance, to children. They're cousins of penicillin. Typically, this is given for 2 or 3 weeks. When studies have compared what's better, 2 weeks or 3 weeks, they were equal. But none of us really feel like those were completely definitive studies. So we can all sort of see, well, I have this patient who had this story that seemed kind of bad about Lyme disease that we're not sure was really studied so well in that comparison of 2 versus 3 weeks. And so we do sometimes give people 3 weeks just to make sure that they're going to respond. There have been some big studies looking at, well, what if we know some people don't get better after the therapy, and we sort of think, well, maybe that was the wrong diagnosis, or a person got a little bit better and then seemed to relapse after 2 weeks of therapy. Would they have done better if we gave them 4 weeks or 5 weeks? There have been a bunch of studies of longer courses of therapy that didn't show any difference between the people who were given longer therapy versus short. And so we tend to hold off on longer than 3 weeks, thinking that the harms of these things, the side effects and other toxicities can be probably more dangerous than they're worth. This one, for instance, you have to check labs every week because bad toxicities can happen on that one. Okay, so what happens? Typically, this is what happens. You feel fine. You know that it's not typically quick. It's the kind of thing where I'd say most people feel pretty wiped out and achy for a couple weeks after they've had Lyme disease, might be able to get back to work after a week or so, but they're not fully back for 3 weeks a month. It takes a while. But that's not always the case. The worse your Lyme was, the harder it is to get over it. So people who have a big fat, swollen joint tend to take longer to heal up as that sort of slowly shrinks down, and it can take months for that joint to feel like it's getting back to normal. And in fact, that may be, some people have arthritis in a joint because of an old football injury. Some people will end up with a sore knee after that, but not swollen, just sore from that injury of the infection. But that's the case with about 90-95% of people. That's not everybody, and it gets to this idea of post-Lyme syndrome. I love this picture. Some people don't, it's kind of the rash goes away, their knee gets better, they get treatment for their carditis, and typically that heart block goes away. It's actually a common scenario in the hospital is that somebody, a cardiologist will call me and say, I've got this guy on the docket to get a pacemaker, but one of the house staff drew a Lyme test and it's positive, what should I do? And I say, take that guy off the schedule, just support him in the hospital for a little bit, he'll probably be fine. Probably does not need that pacemaker. So usually these things sort of melt away over time, and you just have to kind of get through it, take some ibuprofen and you'll feel better. But some people, maybe 5%, maybe 10%, get kind of like mono. Like mono, some people get it and they're fine a few weeks later, but other people, man, it's a year before they get better. They're just wiped out for a long time. I see people with Lyme like this too. They get better from the symptom I can see, but they're just not themselves for a long time. And the natural history studies suggest that of those for whom the diagnosis is not debated, that everybody agrees they have Lyme disease, nobody has had those long-lasting symptoms for more than a year or two. But there are a lot of people who have really long-lasting fatigue, 10 years of fatigue and aches. And the diagnosis of Lyme is a little more debatable. Either it's just positive on the IGeneX test, or it was positive and they were treated and they didn't get better, and maybe they also had depression, and so we wondered, well, what was the worst culprit here? Was that depression? Was it their fibromyalgia? Was it Lyme? Was it that, what? There's uncertainty there. And so that's another part where I put an asterisk, where the dogma is that in 1 to 2 years you should be totally fine. But heck, I'm willing to entertain the idea that it could last longer. It seems to me like bodies probably don't have a clock and they don't tend to go, 24 months, I'm done. So I think it's possible that it could last longer. And you can imagine that some people might be more at risk of that. Let's say if you had fibromyalgia to begin with, and we're still trying to figure out what fibromyalgia is about, but it's a condition that makes people profoundly fatigued and kind of achy. And we think maybe the nerves are hyperactive and are sensing normal life as painful more than somebody else would, but that they really do feel that discomfort. If you had that and then you got Lyme disease, maybe your symptoms will last longer. You can imagine lots of examples of that. Maybe you had multiple illnesses beforehand. It's harder for you to bounce back. So we'll see what time brings. If we only discovered this illness a couple decades ago, so maybe in a couple more decades we'll learn more. What is known is that in people who have post-Lyme syndrome, if you give them ceftriaxone, even that IV medicine, for weeks and weeks, it doesn't, compared to placebo, improve their outcome. Which is really disappointing, because you can imagine people who are diagnosed with post-Lyme disease will come in and just feel desperate and wiped out and want to be the people that they were before. And it's really frustrating to hear, no, I don't think I should give you antibiotics because I feel your pain, but I don't want to hurt you on top of that. And this is another area of dispute that you'll run across. There are docs who will give people with this antibiotics that are sort of not as well studied, but have sort of a plausible mechanism that they might help with inflammation, they might kill the agent of Lyme, Borrelia burgdorferi, and they'll give them for months at a time. And I think it's, generally speaking, out of good intentions. I'd say that there are people in my specialty who say they're quacks and they're just trying to make money off of them. I'm sure that's true for some of them, just like it's true for some of any kind of doctor. But most of them, I think, are just trying to help out, and they kind of hear, I'm desperate, help me, and they write a prescription because that's what doctors do, and I'm not willing to do that because I feel like it has more danger than I can promise is counterbalanced by benefit. But I understand the temptation, and I'm kind of curious to see what happens by the time I retire. Do we realize that 3 years of therapy and then things got better was the answer? But I tell my patients that that feels to me a little bit like human experimentation. Like, well, let's just try this and see what happens. And for me, if it was me or my wife or my kids, I'd want to kind of know that it was likely to work. Okay, so let me touch on co-infection and a couple of other things, and then I wanted to save some time for your questions. So it turns out that ticks, the Ixodes tick that carries Lyme in its belly, isn't only infected with Borrelia burgdorferi. It's got lots of stuff in its body, just like we aren't sterile. And the two big ones that you worry about are Babesia, which can cause an illness called babesiosis, and anaplasma, which can cause an illness called anaplasmosis. And you can see that these maps look really similar to the map I showed you of Lyme. It's sort of, New England and a little bit to the left of the Great Lakes, but, a smattering in California. And so that makes sense because it's the same ticks that transmit them. Babesia is less common than Lyme disease. There aren't nearly as many cases of babesiosis as Lyme disease. Anaplasma is increasingly common, and in the last couple of years has just blown up. We are seeing much more anaplasmosis here. Let's see. So let me tell you more about those stories. So Babesia also can be transmitted by a tick. And here is a slide of red blood cells that carry oxygen in your blood. And these little spots inside the red blood cell are the Babesia parasite. This is a parasite that actually is kind of a distant relative of malaria. And it causes a similar disease. This parasite likes to live inside of red blood cells as they circulate around in your blood. And your immune system detects that and tries to kill the parasite. And in so doing, it kills the red blood cells. So people can come in not only sick with just sort of infectious symptoms, fevers and not feeling good, but they can have incredible anemia. I've seen people have a fourth of their total blood cells destroyed by Babesia. Sometimes it's not so bad. So I'll see somebody who has a little target rash and they're a little anemic, and we test for this and it's positive and we treat it and they're fine. I've also seen people die from babesiosis that was diagnosed too late. This is the most dangerous tick-associated disease. Fortunately, it's rare, but it's something we have to be really careful to look for. And so when we're doing screening blood tests looking for anemia, we're kind of looking for, Lyme will make you a little anemic, but is that anemia worse, and should I be looking for this? This infection is not treated by the drugs that we use to treat Lyme disease. So you have to think about it, or else that person can get sick. Anaplasmosis, on the other hand, this is also a blood slide. And here, this big cell is a white blood cell, and it is what anaplasma likes to infect. And anaplasma, most of the time, is something that's, it's nice to make a diagnosis of, and you can treat somebody to help them feel better sooner, but it typically goes away on its own. In fact, for a long time, we didn't know that some of those people who have Lyme disease, who seemed a little more uncomfortable, a little sicker, sometimes had a little bit of abnormalities in their labs that we couldn't explain. Maybe their liver looked irritated. Actually, many of those people had both. They had anaplasma also. And nearly all of those people just get better on their own. They just feel a little more miserable, but then they get fine. But
white cells bounce back?
They do. It's a clue that it's there is that the white cells go low, but they always come back with treatment. The liver tests are typically just a tiny bit off, and they'll bounce back to normal, but every once in a while they can really startle you as being quite abnormal. This one, on the other hand, does respond to the doxycycline that we use to treat Lyme disease. That's partly why we didn't really notice that it was there, as we were kind of accidentally treating it anyway. But it's useful to know, because what if I was treating somebody with that IV form, ceftriaxone, for their complete heart block, and they weren't feeling better, or their liver tests were a little bit off? I hate to miss this, because they can make it feel better. It's probably not going to... I've never seen anybody get critically ill from this, but I've seen a lot of cases of it. But, man, if I had the opportunity to make them feel better, I would. So, good to diagnose if you see it. Okay. So I've already talked with you about uncertainty and sort of some of the debate around Lyme disease. And I wanted to just come back to that at the close and say that when confronted with illness, patients want certainty. So most of us want somebody who will just say, here's the answer, here's what you can expect, you're going to feel better, you're great, don't worry. That's what most of us want. Clinicians want the same thing. They want to be able to say, I know the answer, I've been well trained, here's your thing, you can thank me tomorrow, right? I mean, that's what we all want. Ego is a little bit involved in both of those, right? I want to be self-sufficient again. I don't want to feel bad anymore. I want to get the best care possible. I deserve best care, as the patient's ego is in there, and I don't question that. I think clinicians' ego sometimes is a little more questionable, and that we kind of say, well, don't question me. I'm the expert. You don't know as much as I do. Don't ask questions. Some patients will hear from clinicians. When those things collide in a space of certainty, you had a heart attack, these are the treatments that will help you live longer, you can work it out. When there's uncertainty, I think that's probably not Lyme disease. I think it probably would harm you to give this treatment. And it's expressed with ego. I think naturally patients will say, that guy's a jerk. I'm not going to listen to him. I'm going to go talk to somebody else. And if that somebody else says, sure, you got Lyme disease, here's a prescription, who are they going to like? Same thing with patients. I mean, same thing with clinicians, too. If that patient says, thank you so much for that great advice you gave me. I see you have a lovely diploma on the wall. I will tell all my friends about how awesome you are. Congratulations for being such a wonderful doctor. Versus somebody else is like, you sure you don't care about me? How come you won't give me this prescription? This other guy would. Who are you going to want to see? This interaction can get complicated, and I always try, I'm certainly not ego-free, a few of us are, but I try really hard to put myself in the patient's shoes and just say, look, I'm in the easy position here. I'm the one sitting there typically feeling well with my stethoscope around my neck, trying to help somebody who feels crappy and just wants answers and wants some help. And so there are absolutely times I just say, you know what, my best judgment is I don't think you have Lyme disease. Or I think you had Lyme disease, but I think now you just have post-Lyme syndrome. And I think the best thing for you, the safest thing for you is not to give you antibiotics. But I try to say it with humility and say, if you're not sure about that, if you're hearing different things, be careful of somebody who's not thinking through it and telling you about the evidence. But get a second opinion, because it's your right to get good advice, and maybe sometimes you'll get a more rounded thought about it. But just want you to know I'm saying no to the prescription, not because I don't care, but more because I don't want to hurt you. And usually people will sort of hear that and say, well, maybe I will or won't get the second opinion, but at least I was heard. And I figure that's probably a good antidote for a lot of what ails in our society, that people can disagree. That's fine. But as long as we all walk away saying, yeah, we both have the same goal, then I figure it's all right. So, most Lyme disease, pretty easy to diagnose, pretty easy to treat, goes away after a few weeks. Sometimes not so easy, and we do our best in the middle. Usually goes away, usually not so hard to treat. And every once in a while there's this myth and reality stuff, and we do our best and try to be humble. So, and then there's scientific progress. Here's Calvin and Hobbes. Curiosity is the essence of the scientific mind. For example, you know how milk comes out your nose when you laugh while drinking? Well, I'm going to see what happens when I inhale milk into my nose and laugh. And she says, idiocy is the essence of the male mind. And he says, I'm guessing it will shoot out of my ears. Don't you want to see? Experiments are being tried, and eventually we'll get the answer. All right. So what's on your mind? What wasn't clear, or what questions do you have? Yeah.
Thank you. It's fascinating. And the question of uncertainty, it must be the case that many diseases have that kind of diagnostic uncertainty, where there's a trade-off between the false positives and the false negatives, and you don't know whether it's worse to miss a positive or to miss a negative. So wouldn't there be a body of work on sort of the logic of probability that encompasses all diseases where there is that kind of uncertainty, or is there something specific about Lyme that makes the testing much more uncertain?
Yeah, it's a great question. So it turns out that part of my work is with the Dartmouth Institute is where a lot of the epidemiologists at Dartmouth are. And epidemiologists have done a great job of describing sort of the math behind these probabilities involved. How good is a test at diagnosing an illness, or how likely is a person from a given population to have a given illness, and how do those intersect, and so how much certainty can we have out the other end. So there's a good language about that, good math about that. It turns out that we are all really bad at operationalizing that math. And that's true even for people who have been trained in it. It's just really hard to think that way. So partly, although the science exists and a good epidemiologist can just kind of pull that out of their back pocket and talk about it, most clinicians and most patients have a hard time talking about it and thinking about it clearly, and that complicates things. The other piece is that some situations are also just a little harder to grip onto with that information. An example is, so I was talking earlier today to some graduate students about HIV infection, and I was talking with them about HIV testing. An HIV test is, in somebody who has had HIV for more than 42 days, is 99.9999% likely to give you the correct answer. It is so much better than a Lyme test. Or, that is true of, say, if somebody has a lung mass and we do a biopsy that we look at under a microscope. If that pathologist says, I am certain that's lung cancer, that's lung cancer. Lyme disease is just not quite so tractable. It's, I think it's probably a mixture of we haven't quite come up with the best technology that ultimately I think will diagnose. And then some illnesses are so protean that it's a little harder to kind of pin down, because in whom should you do the test ends up being the challenge. I would never biopsy the lung if somebody had normal lung. And so I never get those normal lung answers, or I rarely get normal lung back as the answer from the lung biopsy. But a blood test, heck, that's not such a big deal. It's easy to do. Mm-hmm. So it's a mixture of those reasons for uncertainty.
So the bacteria that cause Lyme disease cannot be detected in looking at the infected tissue under the microscope?
Yeah. So that's a part of it, is that one reason why the technology is kind of crappy is that we're pretty good at detecting the immune response to those bacteria. Mm-hmm. And there are some, for certain body tissues, there are some PCR assays, some really sensitive molecular assays that can pick it up. But you can't do that on many tissues. In microscopic exam, just not great. Culture doesn't work. Whereas for so many other things, staph and strep, we've got 5 or 6 different tests. They're all pretty good. But I think of that as a temporary obstacle, because every year we come up with new testing and new cultures. So ultimately they'll look back and say, boy, those guys were daft. Why didn't they just do this? Yeah.
What do you do if you remove an engorged tick?
Yeah, I didn't touch on that.
No bullseye is, you don't know if it's been on there for 12 hours or 24 or...
Yeah, that's a really common question. It kind of gets down into whether you like to parachute. So it turns out that about 1 in 100 ticks in endemic areas will be infected with Lyme. And so if you find a tick on your body and it's just crawling along, that hasn't had a blood meal yet, so you don't care, you just brush it off, no big deal. But if you find a little nymphal tick that's got a swollen stomach, now you've got a 1 in 100 chance of getting Lyme disease. And so different people will respond to that in different ways. I always offer people a dose of doxycycline. And studies have shown that the likelihood of getting Lyme disease after that is basically 0. Some people will get some side effects from that dose of doxycycline, but usually 1 dose is no big deal. But some people will say, well, 1 in 100 chance of getting an illness, some chance of getting some side effects. What bothers me more? Could I just watch this and see if I get a rash and then come in and get treatment for that, knowing that, oh crap, now I have to take the antibiotics? Some people will pick that option. Other people will say, I'm not going to be able to sleep unless you treat this. And so I always sort of say, it's like, you could either watch it or treat it, but I'd be happy to give you a prescription for a dose of antibiotics.
Do you test that tick?
Not clinically. The state actually does this every year, or actually they have been, although I hear that the budget cuts are making it so that they're thinking about not doing it.
And there are organizations that do it, that you can send it off and pay.
Yeah,
There's a place in Winooski or somewhere, in Vermont,
that's right.
$60, send a tick. I mean, if you've got a bloody tick that was on there for 36 hours. Yeah, because then I didn't worry. I sent a tick.
Yeah.
It wasn't mine.
And for me,
It was a dog tick, it wasn't a deer tick. But
That's
I mean,
exactly, that's what's
the
really
other
helpful.
thing, yeah.
Is it, those
But
big
it was
ticks?
tiny, it was tiny.
Oh, really?
Yeah, it was little.
Like a baby dog tick.
Yeah.
That's what's really helpful is every once in a while you can find somebody who's pretty good at the ticks and they'll say, oh yeah, that big one right there, that's a dog tick. No
Right.
chance of Lyme, but sometimes it's just hard to tell.
But the dose of doxy for the preventative is only 2 pills, right?
Yeah,
200
it's 200
milligrams.
Yeah.
Yeah, so it's just a one-time shot, so that's pretty good.
Yeah, I mean, for me, I'd probably just take it and be done with it, but some people that, the risks or the downside.
How much time do you have when, say, the one tick in 100 that has it and it's on you?
Like before treatment needs to happen?
Well, I mean, do you instantly get Lyme disease? And like if that tick gets on you and bites you,
It looks like
do
you
you
have
get
about
it
a
instantly?
week. Yeah, it looks like you have about a week. So like if you find that tick and take a dose within a couple of days of finding that tick, almost nobody gets Lyme disease. So it looks like there's that opportunity to nip it in the bud.
I did that.
Yeah.
I've had 3 or 4 actually in me.
Mm-hmm.
They don't seem to just bite me and fall off. They keep going.
And this is a real thing that people have studied. I feel bad for the people who are in the studies, but they've actually looked, you'll hear in conversation, I'm just a magnet for those things. And I've always thought, you think you're a magnet, but it's true. Some people, we think maybe it's like a smell, a pheromone or something like that. The ticks are more attracted to
Some people get poison ivy and some
Yeah.
people don't.
Yeah, so they're out to get you, it sounds like. Tom, did you raise your hand?
My question is answered. The dose is
Oh,
just 2 tablets.
Yeah, that's right, it's 200 milligrams, just once.
I have another question, which is this true that if you test positive ever, you always will?
That's generally true, it's not 100% true, but I keep going back to HIV, I guess I have it on the brain, but just like an HIV test is almost always positive for the rest of the life, because it just means your immune system remembers that it's had this infection. That is true of Lyme disease as well. There are 2 caveats. One is that in a complexity that I glossed over a little bit is that the test actually, I'd said that there's that one screening test and then there's a confirmatory test. The screening test is positive or negative. It just says, do you respond or not? The confirmatory test actually gives you a much more complicated result. It sort of looks for multiple antibodies to Lyme and says you've got A but not B, and you've got C, D but not E. It turns out that if you watch over time, somebody who's definitely had Lyme disease, they got treated, some of those tests will go negative over time. It's probably your immune system saying, all right, I was really fired up about that infection, I'm upset, I'm throwing everything I've got at it. All right, I haven't forgotten, I know that I had that, but I don't need to do that, and so I'm going to, put some of those guns away. That does happen, and as a result of some of those levels of responses going down, in rare instances, people will go to negative. It's
On the confirmatory.
on the yeah, that's right. Even on the first one, because the first one's measuring sort of the total amount of all those guns. So most people, 95% of people, they'll always be positive, and so testing it positive again, I kind of think, yeah, I already knew that, you already had Lyme disease. Some people, though, I've very rarely seen this where they were positive, they got treated, it went negative because somebody checked for some reason and I knew it was negative, and then they were positive again. Well, that's useful. But usually it's just positive and now they're positive again, and I say, well, I kind of expected that.
Well, I read somewhere that when you test for Lyme disease, that you're looking for a spirochete, and it knows somehow that you're looking for it and changes into a spore. I just read that. I don't even almost know what I'm talking about.
Yeah, there's sort of like echoes of the way I put it. So a spirochete is the kind of bacterium that Borrelia burgdorferi is. You can kind of hear in the name, it's a spiral-shaped organism. Interestingly, it looks really similar under the microscope to the bacterium that causes syphilis.
Yeah, that's
They're
what,
both spirochetes.
that's what they were saying.
Yeah, and those bugs, both syphilis and Lyme, are both known for funny disease presentations.
The great pretenders.
The great pretenders. They do things that are a little hard to diagnose. They have sort of protean manifestations. And one of the reasons for that, we think, is that they play games with the immune system. They actually have a way of cloaking their proteins so that it's harder for the immune system to fight them. And that's probably why, instead of just getting rid of them like a cold, it can last for weeks and make you sick in funny ways.
Right.
Depending on, you can imagine that if maybe you thought a particular part of it, that's going to protect you from arthritis, but if you miss the part that could get into your brain, that happens.
And that's what makes the test a little bit
So that
not perfect.
that's the connection that I've heard people raise that I haven't heard made, that the test is measuring whether you make immune responses to the Lyme, and we know that the immune responses to Lyme or to syphilis are not as powerful as they should be to control the infection. But I think the tests are, like, you can still see that the body's making a response. That makes sense, that the Lyme testing still works pretty well to show you that your body knows it's there, even though the thing that it's responding against isn't controlled by it. And the, sorry to flog a dead horse, but it's the available analogy is HIV. HIV testing is positive. I can see it in somebody, even though our immune response doesn't clear it. Those antibodies don't do a lot, but they're there, so I can see them.
Right. Yeah.
Somebody,
Myth or fact, I've heard that the tick has to be actually in you for a certain amount of time.
that's right. We think overnight is necessary, so you need to
Overnight.
have. Usually, people will take it off as soon as they see it, and they don't know exactly how long it's been there. So the thing I'll use is engorgement. If that tick has been there long enough to fill up its belly with blood, that's probably long enough for it to get there.
But if
Every once in a while, though, somebody will say, I checked, and I know I did not have a tick there, and 12 hours later, there's a tick that's a little bit engorged. That, we think, is not long enough. But it gets into the same conversation of how much do you like to parachute. Some people say, well, is it 100% at 12 hours? And I'm like, well, it's probably 99%. You want that doxycycline?
just getting a tick bite
Yeah,
is not enough.
that's fine. Yeah, that's no big deal. It's that it has to hang on there long enough to barf up that bug into your blood. Yeah. Oh, actually, I think you were next
Oh,
on.
that's okay.
Sure.
Will there be a vaccine? And is there any protective effect of having Lyme disease for later?
Yeah, the answer to both is yes. And so it's clear that having had Lyme disease once does help protect you from Lyme disease. Not perfectly, though. It's like having had tuberculosis. You can still get it again. It's just less likely. That observation that people had Lyme disease once were less likely to get it again, which is a complicated thing because you can imagine that if I've had Lyme disease once and then I move to Wisconsin, excuse me, I could get it again. If I have it once and then I move to Utah, it's really unlikely I'm going to ever get that again. And so some of these studies are complicated by where people live. Anyway, so the observation that people looked a little protected led to vaccine development. And actually about, I want to say like 10 years ago, a vaccine that worked was developed. And it's now not on the market anymore because there wasn't enough of a market and they couldn't sell it. So actually it's still out there being used in dogs, which is nice. But we all kind of, what's the deal? How so many people get Lyme disease and the numbers are just growing over time. So my guess is those numbers are going to reset and that it wasn't a great vaccine, so just like having had it, it wasn't perfect protection. And I hear that there's a clinical trial of a vaccine they think might be better. And I think that's them anticipating the fact that Lyme cases have been growing over the years and over time there will be a market.
Mm-hmm.
Have you guys heard the interesting theory about why there are more cases of Lyme?
No.
Nice.
The mice?
Dear.
So deer, but why?
Global warming. Weren't they in the south?
So that's one, is global warming. We think that there's probably more time, more good days for the ticks. Ticks don't do well in winter, so there are more warm days during which the ticks can live. There's more chance for them to hop on our bodies. So that's one theory. Another theory is has to do with development and regression of development. So as many of you know, many of the towns in this area were deforested to make way for farmland, but then the forests have grown back. And at the same time, developments have moved into forests. So we think it might be some mixture of global warming's making it so there are just more ticks available, and humans are sort of at the edge of that habitat for one reason or another, sort of being exposed to forest.
I get more ticks on me
Mm-hmm.
I work outside, like in Hanover and Norwich, in particular downtown
Mhm.
area. You know, the house is just out, like say Rip Road and that stuff.
Yeah.
And I climb a lot of mountains and stuff, and when we do that, usually you don't see a tick.
Huh,
So
interesting.
it seems to be more rural than,
That's interesting.
and now there's some places where if you hike like down around Lake Winnipesaukee or something, they'll be crawling all over you, the little tiny ones, but you go
Yeah.
to like the, you know, Lincoln and Lafayette and White Mountains or something, and
It's fascinating how there are little pockets you can, when the state has done that, when they do those nets and they test for ticks, some places are hot spots for ticks, probably because of the microclimate, the humidity, the temperature, the foliage is just right, and other places are less so. So it's
we
fascinating.
never had ticks around here. I was born and raised here, and we run around the woods like, you know, with a pair of shorts and no shoes or anything. I lived up on Poverty Lane behind the airport, and we just run all around.
Yeah.
And the first tick I ever got on me when I was 50 years old.
Yeah, it's crazy to
Since
see
then,
the
I've had,
the map of
Eight or
Lyme
10.
disease has just gone right up New Hampshire and Vermont. It's crazy.
I had heard that the deer population has been expanding.
Yeah, definitely.
Because of the lack of predators, you know.
deer and mice and
35 years ago, there were animals that killed the deer.
Yeah,
And more
we're
hunted.
closer to them and they are more numerous, and the ticks that are getting on them and living off of them and then hopping on us are more numerous. So it's kind of a perfect storm.
and Joan is saying that possums eat ticks.
I don't know.
Yeah,
There was an
and
article on them.
their skin, ticks can't get through their skin.
Oh, that's interesting. I've never heard
There
that.
you go. There's your-
Yeah, cool.
We never had possums around here originally.
Yeah, but they're here now.
Is there an effective repellent that humans can put on or that you can put in a yard? I mean, those would be two different.
Yeah, we
I
think.
was gonna ask about the
applications.
spraying the yard and what they use, and do you know whether it's
You know, I know the
useful?
state spray.
Chippers is doing it too.
I'm not sure actually what they use. I haven't heard, you know, epidemiologists.
Chippers said they have
report
both organic and inorganic, and pesticide.
that.
And
Yeah.
I didn't call them yet to find out what it is, but I wanted to ask you whether you
Yeah, I
knew
don't
if
know.
it was effective.
I'm not sure. That's a good question. I'm not sure.
I spray the
Deet.
bottom of my boots with just a spray because I figure they're on the ground and they're gonna climb up. So just by spraying just this
Yeah.
bottom every day before you go out seems to help.
With what?
Like at Dan and Witt's out where they sell the mouse traps and stuff like that, they have 2 or 3 different kinds of spray that you can buy, like a bug spray, and some you can put on your skin, some you just for your clothes. But that's not gonna help you if you're
Yeah.
crawling around in the garden.
Well, I
or
read
something.
on the CDC website for Lyme disease that, I forget the name of the substance, that they recommended covering your clothes.
Yeah,
Yeah.
DEET, or the
Permethrin.
permethrin for the clothes.
And the none
DEET
of them are
is-
perfect, but it does seem to help. And
Yeah,
you can
just-
actually buy permethrin embedded clothing.
Yeah.
You can buy, DEET bug repellent, which has some effect but isn't perfect against ticks. But you can get permethrin coated clothing, and similarly, it's not perfect, and you can still get it.
It's like chrysanthemum, and it's like a permethrin, it's like chrysanthemum flower.
it's kind of like if you use off, for black flies and mosquitoes, it kind of works a little bit.
Yeah.
They say that they don't like the smell
Yeah.
of
What's
flowers.
There are a lot of new tick remedies, well, repellents
Mhm.
that are more organic than not,
Mhm.
that my walking group and I are crazy about, because so far we've had pretty good luck with
Oh,
them.
that's good.
And there's cedarwood oil, geranium oil,
Mhm.
citronella, lemongrass, and several other organic essential oils mixed together.
And do those work when
Well,
they're
so
compared to
far, it's a very young season.
And you were gonna say.
Cedar oil,
Spray
my
water.
son who's out in the woods a lot and has had
Spray.
to be treated
You know,
for
chaps
some
that are
kind of
impregnated.
Lyme.
Or chaps are fairly
Lyme
expensive.
measles.
like
Swears by
$40
the cedar oil.
Well, I hope that thing's really great.
The spray was, I think.
They bought
$1
like a
cent.
bunch of it at the camp he works at.
You gotta spray your clothes today, before let it dry.
My sense of the room is that we're starting to chit chat, and that sounds great. Maybe a good time for me to say thank you for having me and get off the stage.
Thank you.